Morning, everyone. Welcome to Grind Round. August the 31st? It is still August the 31st. I thought we were in September. Today's speaker is Dr. Kelly Henchel. She is an outpatient pediatrician at the Jefferson Plaza Pediatric Clinic. She is the section chief of outpatient pediatrics and an assistant professor of pediatrics, Virginia Tech Carilion School of Medicine. She's been with the Carilion system since 2010, coming from North Carolina and many years as an outpatient pediatrician. She hails from Michigan, hence the Detroit music, the Motown this morning. Trained at Wayne State University School of Medicine and did her pediatric residency at St. John's University Health System, all in Michigan. Please welcome Dr. Kelly Henchel.
All right, I'm clipped on my badge. I don't know if we're mic'd up. Oh, apparently we're mic'd up well. So I've had the great pleasure of getting to be part of an AAP project in screening in general pediatrics, and was able to travel to Chicago a couple of months ago for a action-packed, loaded 2 days speech and conference and QI rev up on how do you do all of the screening in outpatient pediatrics that you need to do to be a good pediatrician. And that's thanks to Ryan Fulton, who applied for the project, and we were accepted, all 4 of our outpatient sites across Carilion, to be part of this. So thanks to them, I have used a lot of their information. Most of what you're going to see is passed right along from them. But the problem is, oh, by the way, I have no disclosures. That is about my wallet right now. There are definitely flies and dust flying out of it. This is what you have to do in your checkups, right? It doesn't look daunting at all, does it? So that's all you have to do. You have 10 minutes, you might have 20, and if you're really, really fortunate somewhere in the world, you might have 30 minutes. And as you go down the chart, each of the dots is something you're supposed to accomplish, and as you go down from north to south, it's you in your 2 months, 4 months, each of your scheduled checkups, and that's all you have to do, right? So how do you get all of your screening done that you need to get done, and how do you make sure you're catching things that can actually impact the health and welfare of the children in your practice? Surveillance, of course, is what we do every time you walk into the room, and the first thing you ask a parent is, hey, what's going on? Do you have any worries or concerns, right? And that's the number one thing, is you're eliciting from the parents any concerns about the development, learning, or behavior of their kids, and, you know, asking them, do you have any worries about their behavior, about how they're learning, about how school is going? And, of course, that's what we're all doing all the time. You also need to ask parents about what their family strengths and risks are. Are you in a home? Do you have food? Do you have support? Are you all alone? What is going well for your family, and what do you need help with? And, of course, this just happens through conversation and observation. You can watch the child in the room for that brief time and get some of this, but you certainly can't be a great judge of where the child is at. So that's where screening comes in. Screening is a more formal process by where you use tools which are vetted and validated to identify kids that are at risk for learning disabilities, for autism, for mental health issues, for toxic stress in their lives, and to help you pick up the more subtle things. Examples of that are the Ages and Stages questionnaire, the PEDS survey, the SWIC, the PSC, the SDQ, the Edinburgh, the SEEK, you know, the list goes. I could drop it from the ceiling to the floor. But those are some of the most popular ones that we find that the practices across the United States participating in our project are using. Beyond that is what goes next. Well, beyond your screening is to determine, is there something further to look into? And that's not our job in the medical home to make the evaluation. So that's where you're reaching out and making your referrals to your specialists, to your pediatric developmental clinic, to your psychiatrist, to your psychologist, sending families for help with housing, with food, with getting their insurance, everything that they may need to help reduce their stresses. So not what we have to do in 10 minutes. So what are the AAP's guidelines? What do they say we should be doing in our brief appointments with these families? Sorting out the big overbearing chart in the beginning, this is what it whittles down to for what should we be screening when you see kids in your practice. General development screening, not just surveillance, is recommended to be done at the 9, the 18, and the 30-month visits. Just 2 years ago, that was recommended at the 9, 18, and 24-month visit. And so as our practice moved through this, we decided we were actually finding a lot of language delay at 24 months, and we kept the official screening in place at 24 months rather than just surveillance because we felt like that was an important part. So this isn't all you, I'm sorry. I have a child at home. Make sure he's not. No, we're good. Sorry. Make sure he got the bus. Don't know what I would have done otherwise. Someone would have been driving. Apologize. So this isn't, you're welcome to use official screening at every routine child visit, but these are the critical ones according to the American Academy of Pediatrics where you need to have them done. You should be doing social and emotional development screening regularly, autism screening at 18 and 24 months of age, maternal depression screening or postpartum depression screening at 1, 2, 4, and 6 months of age, and at every visit you should be inquiring about their social determinants of health in your brief time. So what are the benefits of using the structured screening over just using surveillance with your patients? It increases the reliability of the whole process. Of course, if you're seeing a child and you're just doing quick observation and quick questions to the parents and you say, hey, how's everything going? And they say, everything's going great. It's kind of like me taking my car to the mechanic and they say, how's everything going? I go, everything is going great. But I don't know that belts need changing at some point, and I don't know that my tires should have this much tread, and I don't know that my antifreeze needs checking or anything else. So if you're just asking parents, hey, how's everything going? They say, everything's great, I have no worries or concerns. They might not know what to be concerned about. So using your screening triggers those parents to know where their child should be, to recognize that, hey, maybe my child isn't doing as well as I think they are, or yeah, my kid is a superstar. So it gives you that template for conversation. It helps you set those priorities, because remember, you don't have an hour with this family. You have very few minutes. It guides your discussion, helps the parent to make sure that you're getting their concerns and questions answered. And there is evidence to support that you get more candid responses with the questionnaires than with direct questioning, which is always interesting to me because, parents want to please us too. So they lots of times tell us, we were talking about this in the clinic yesterday, yes, I'm going to the dentist. Of course I take them to the dentist. Well, sometimes you have to take people at their word. But, yes, my child is perfectly well. There's no problems at all. And in the back of their mind, they're thinking, but, he does this really funny thing. I sure hope he doesn't have autism. But it might be hard for them to say that to you, where they might then uncover that through some of your screening. Why else do we screen? Because you cannot reliably detect delays during a 10, 20-minute visit in the room with the patient, right? There's just no way you're going to see all the behaviors. Some of your 2-year-olds are going to scream from the minute they pull in the parking lot to the minute they pull out. Does that mean the kid's autistic, or he's just terrified because he remembers his catch-up shots from the last time he was there? Parents, of course, know their children the best, so you need to elicit their input. It actually does increase parent and provider satisfaction to use screening over surveillance, and it facilitates your discussions. And, of course, for parents, knowledge of the development is a key protective factor. Like I was mentioning, if you don't know where your kid should be, you might think your kid is perfect, and your kid may have some areas that we could help with and improve. I don't know how I made one pop up, but I did. So we're not going to do all of this today because there's no way we could talk about all of this in an hour. That would take me all week. What we're going to talk about is the 5 things that I've added here. In that order. We're going to talk about maternal depression screening. How do you start that? How do you work that into your practice, and why are we doing that? The autism spectrum disorder screening, developmental screening, social and emotional health and development screening, and then the social determinants of health, which I think probably poses the biggest challenge to us as a community because the resources can be little known, and getting buy-in, it can be difficult. So maternal depression, maternity or baby blues. 50 to 80% of women will have just the baby blues. It happens in the first few days to 2 weeks after birth. It is more transient, depressed mood with some irritability, crying, anxiousness, may feel afraid or confused. And what do you do if you find that a mom is just having the baby blues? You ask the families for support. You ask her to reach out for support from the family. You also ask the family to support the diet of the mother and the child to make sure that, that she's having the help she needs to provide bonding care with that baby. Postpartum depression actually occurs in 13 to 20% of women who are new mothers, and this can occur anytime during the first year. It meets the DSM-5 criteria for minor and major depressive disorder with depressed mood, reduced interest in activities, loss of energy, and difficulty concentrating. What do you need to do first? You need to treat mom. Mom needs help. She needs family support. She needs a mental health provider, possibly a psychiatrist, and the mother-baby unit needs help. They need support. We need to make sure that the mom is bonding with the baby. We need to help her through any of her fears and make sure that the baby is bonded well with mom and hopefully continuing to breastfeed. Postpartum psychosis is rare. 1 to 3 women out of 1,000 mothers. Rare, but not so rare that we won't see it. It occurs in the first 4 weeks after birth, and it's way more severe. You have paranoia, mood shifts, hallucinations, delusions, scary, suicidal, homicidal thoughts, and this is emergency. This is mom needs to go to the emergency room. Mom needs to have emergent help, not sent out of the office, not can you drive yourself and your baby to the emergency room. And of course, then there's going to need to be a lot of support with early childhood mental health care for the baby and mother's dyad. So maternal depression, peak occurrence is at 2 to 3 months postpartum for the minor depression and 6 weeks postpartum for the major depression. And so we have opportunities in our regular screening and visits with infants to affect and help moms identify if they're having problems. Factors which increase the rate, 40 to 60% of parenting teens and other moms who have low income will report depressive symptoms, and 25% of parenting moms with low income have depression overall compared to only 12% of the general population. So there are several different screening methods you can use. The simplest screening method would be your PHQ-2. So 2 questions, just 2 questions. So it does not take a lot of time. And these are the 2 questions that you use, and I'm sure everyone is familiar with the PHQ-2. And the question is, in the past 2 weeks, how often have you been bothered by or had problems with having little interest or pleasure in doing things or feeling down, depressed, or hopeless? So when you do the PHQ-2, if you have a positive answer on either of the 2 questions, you need to go further. This isn't enough. So you can move on to the PHQ-9, which is the same screening that we are using in teenagers in the pediatric world to screen for depression. And this then gives you the 9 questions whereby you can dive further into whether or not the mom is actually having problems. Questions 1 and 2 are still your most important. If you have no problems with questions 1 and 2, your chances of actually being clinically depressed are quite small. So those are your key driver questions. But then you're scoring the whole entire thing. A score less than 10 is normal. A score greater than 10 or 12, depending on which source you're looking at, means that you should trigger and look for some help. This is the Edinburgh Postnatal Depression Scale. I know it's hard to read, it's being squished onto one slide. But this scale actually has a very nice specificity and sensitivity for postpartum women and women during pregnancy. So this is the screen that we're going to be rolling out in our clinic next month. This is a very nice screen. It has to be answered by the mother. So the only problem that I see is, you know, we have the mom holding the baby, juggling baby, trying to answer questions. If she's getting outside input into answering this, it skews your results. So you can't have dad holding the form and asking mom, do you feel this way? Do you have this? Do you have that? It really needs to come from the mother, as do our teenage depression screens. So my favorite thing with the teenage depression screen is walk in the room and the mom's holding it and answering for the kid. You know, it's not useful in that way, so this has to be answered by mom. And it's a quick 10-question questionnaire, so it's not overly daunting and very quick to score. So if mom scores the 12 to 19, she needs a referral. A score greater than 20 or a positive to question 10, which was, do you have thoughts of hurting yourself? Yes. then you obviously, or someone else, then you're not going to send her out with her baby from the clinic. And so that could trigger you to look for immediate care, whether or not you needed to get a reliable family member, caregiver, someone to come get her, bring her to the emergency room for an evaluation, whether you can get her hooked up immediately with a mental health care provider in the community. She needs to have immediate care. So why do it? Look, you get RVUs. No, this is about the health of the baby. But I do think it's really interesting that we get a very tiny bit of credit for doing screening in our RVUs. And the billing code actually changed at the beginning of this year and is now 96161. So it's important that you know the billing code and use the billing code for your screening because you are going to get credit for doing this. Referrals for the mom. Of course, her PCP or OBGYN, she has at least an OBGYN who's been doing primary care with her, so that's a great place to go. There's also this great website, which is postpartum.net. It lists by state, and you can click on your state or you can click in your state's name. It gives you the local resources. It gives you online resources, online support groups. It really gives you a lot of nice support for the mom who might be a little bit less depressed but might need some help understanding what's going on. Of course, you have the emergency room crisis one is also available for the severe. So why do we really screen? It's not about the 0.13 RVUs, right? There's a lot of things that you would do would be a little bit more fun than screening for that. But of course, if you have an adverse, if you have a mother who's depressed, the baby does not bond with the mother, you have adverse effects on the infant brain development, compromises the bonding, the babies may avoid interaction and attachment becomes a risk. Emotional, social, intellectual, language, and physical development all become at risk in a baby who doesn't have attachment with their mother. You have family dysfunction in families with depression. You have cessation of breastfeeding, and we all know that breastfeeding is very important for our children. And then you have the moms, and we've all been on the receiving end of this, the moms who are coming in with inappropriate medical questions about their children, who come in twice, 3, 4 times a week because they just are so afraid of their baby. They're not compensating and they're not coping. So it's driving up the cost of the medical care. In the long term, that baby's insecure attachment leads to behavior and conduct disorders. So this is something that we can help prevent right from the get-go, making sure that they're bonding. And actually, the babies end up with an increased cortisol level when they're preschoolers, and they have more anxiety, social weariness, and withdrawal. And we all know that increased cortisol can have increased weight implications, too, so it becomes an ugly spiral. The adolescents in childhood, children who have depressed mothers, have been shown to have more behavior problems and mood disorders. So as you go across the spectrum of this child's lifetime, that early first 6 months and identifying that the mom may be depressed is clearly an important thing to be looking for. So that's maternal depression screening. The way we're going to roll it out in our offices, we're going to have the front office hand out the maternal depression screening at the 1, 2, 4, and 6 months, which are those AAP recommended milestones. That doesn't mean that if you as a provider walk in at any of those other times or they're there as a sick visit and you are concerned about the mom, that you might ask her to fill out the form again. You know, those aren't the magical, hey, if she's going to be depressed, she's going to show up here. So feel free to use that form at your disposal. Make sure that you have it available, that if your nurse says, gosh, I'm not sure this mom is coping so well, you can go ahead and have her hand the mom a form and make sure that you're not missing something. Once it's handed out, it's quick to score it. The scoring is 0 through 2 for the answers on there, for not at all through frequently, much like the PHQ. And you're going to score it quickly to see if your score is of the 10 to 12 or greater to see if that mom needs help. And you're going to discuss that with them. You know, social depression has still carries a lot of social stigma with it today. So for our front end and the front staff in our offices, and you should make sure that they're telling the moms, everybody gets this. We're concerned about you and your baby's health, and every mother gets this at these visits. This is a routine part of what we're doing because you don't want them to feel like they're being singled out. So make sure that you're dialoguing that this is something everybody does. We're concerned about you and your health as part of the health of your baby. And that will help with any resistance or pushback that you have. And so that's how to roll that one out. It's fairly easy. Should be scanned into your medical record, and you do bill it with the 96161, and it bills as on the baby's chart. You're not opening the mother's. You're not billing it to her. This is part of your bundled care for your newborns and infants. I think everyone knows about autism spectrum disorder screening, but there are lots of different screens that you can use. I think most of us have a favorite, and so it becomes quite commonplace. But of course you're screening for this because it's very common. 1 in 68 children now have been defined as having an autism spectrum disorder. Many of us that have been doing this for a long time will tell you, quote, we know an autistic kid when we see one, but you know what? The screening picks up the subtle kids. The screening picks up the subclinical autistic kids who are on the spectrum. Those kids you're not going to necessarily pick up in your 10-minute office visit. So screening is really important. Of course, early identification leads to your early intervention. It improves their skills, abilities, future, social process, job success. So it's really, really important. Remember, you're using your screening to look for those asymptomatic cases. I know we've all been in an exam room. You've given out an Mchat screening form, and you're looking at the mom like she must be crazy because she's answered 4 or 5 questions positive, and you're looking at her kid thinking, there's no way this kid is as normal as could be. Those are your asymptomatic cases. Those are your kids who once upon a time maybe were said to have Asperger's. They're on the spectrum. They have autism spectrum disorder. They're just not severely affected. But again, that early identification and early treatment is super important into their future success. This is the Mchat. Everybody has seen it before, right? This isn't new to anybody. It's probably the most common screening used for diagnosing autism. It is a validated screening tool, and it is available to be used as early as 18 months of age. Many of the other screenings are not available to be used until 4 years of age. At 4 years of age, you've really already missed a great opportunity to help these kids. Students, residents, I don't know who's going to get this one. All of these should be answered as yes, right? Does your child enjoy being bounced and swung? Do they have an interest in other children? There's 3 on here. Can you guys read it at all? There's 3 on here where your answer should be no. Which are what questions? I love that. 2, 5, 12. What are we asking it to? You shouldn't make unusual finger movements in front of your face. I will tell you that's the #1 question that you are making follow-up when you're asking parents to fill this out. Because all kids are doing this, and all kids are finding their noses and fingers in their mouth and exploring their faces. And so everybody answers that one yes, or 9 out of 10 of my patients answer, yeah, they're always poking at their eyes and things. That's not what we mean. Exactly what you guys were all doing in the back of the room, wiggling your fingers in front of your face and being more interested in watching your own hands and what's going on around you is unusual finger movements. What are the other ones that you should not have as yes questions? I mean, as no, yes, that should be answered as no. You shouldn't be making unusual finger movements in front of your face. You shouldn't be afraid of loud noises, but it's so interesting to me because I have so many of my patients have a #1 because nobody likes a vacuum. And that tends to be the only thing they're afraid of, but yes, afraid of loud noises, everyday loud noises. And the 3rd one, everybody's pointing at their ears, which nobody on the phone can hear. Yes, have you ever wondered if your child may be deaf? You shouldn't have wondered if your child is deaf. So when you're scoring this, and this is the revised version, and there are follow-up questions that you can use if you're going to go back through them. So if they answer 0 to 2 and it's less than 24 months, so they're on time for their 18-month checkup and you're giving them their first Mchat at 18 months, they score 0 to 2, they should be screened again. So you want to screen them after their 2nd birthday to make sure that they're consistently scoring in the 0 to 2. Kids who score in the medium risk 3 to 7, that's when you want to use your follow-up questions. Again, my most common follow-up question is, hey, what do you mean by unusual finger movements in front of their face? Oh, they're always finding their eyes. Okay. But there are structured follow-up questions that you can use in follow-up if you need to. So if you come in and you have 7 abnormal questions, pull your follow-up questions and spend some time and go through with that family to see if they're actually positive. If they still have 2 or more positive, then they should be rescreened or referred. There's really no sense in waiting once you've identified an abnormal, because the earlier you intervene, the higher chance of success you have. Kids who have 8 to 20 of them, get 20, refer them. Don't spend time with your follow-up. There's no need. You're not going to change 20 down to 2 questions in most cases. But of course, you're going to discuss with the mom what are some of the behaviors, what is she seeing, what are her worries and concerns. So they need a diagnostic evaluation, which again is beyond the scope of your practice in a general pediatric office. This takes hours. It doesn't take minutes. We're not set up to do diagnosis of autism. There's times where you're sure of it, but you don't have the ability to take care of all of that and get them started in early intervention immediately. The sensitivity and specificity is really, really high. It tickles me that they say it takes 5 minutes to score it. I would challenge you to say it takes about 5 seconds if you have 0, because you're looking, are those 2, 9, and 12, 2, 5, and 12 all answered no, and the rest yes. That's not a 5-minute score. It does take parents somewhere around 5 to 10 minutes to fill it out. So it always makes me really proud when I walk in the room and they haven't had time yet to fill it out, because that means I'm running right on time. So it's a lovely gauge of how your practice is going as well. What else is out there for screening for autism? There's a child autism checklist for 4 to 11-year-olds, a social communication questionnaire for 4 and up, and the survey of well-being of young children, which is a much longer form, also for older kids. Because we are in general practice wanting to identify them early and start treatment, the Mchat is the one we're all routinely using. And we found that as we met with the group in Chicago that everyone uses Mchat. Across the other screening, whether or not you're using the PHQ 2 or 9 or the Edinburgh for your maternal depression, there's a lot of variation across the country, but Mchat is pretty standard. Developmental screening. Why screen for development? 15% of the children have some form of disability. So this isn't something you're going to only find on a rare occasion. This is, 3 of the 20 kids who come, 1.5 kids doesn't work. So 3 of the 20 kids you're going to do checkups on this week are going to have something going on that requires further attention. Speech and language, mental retardation, learning disabilities, or emotional and behavioral problems. We're really, really, really good at looking at the solid things and making referrals. We're much more challenged when you're looking at the emotional behavior problems, what to do, how to help the family, the dyad of the parent and the child, which in many cases plays the biggest factor in there. The embarrassing thing to me as a general pediatrician, and I know all of you that have teacher friends will validate this, only 50% of these problems are we picking up before those kids start school. So you think about the number of school forms that we've all just done and said these are normal kids, normal kids, normal kids, and the teachers are coming back after the first 6 weeks and saying, oh my God, those pediatricians must be insane. Half of they're picking up these 1 in 10 kids in their classroom of 20, so they probably have 3 kids in there that are abnormal, and we've tried to tell them they're all going to be normal and fine. So using the screening is really important to help to try to pick up, to help these kids work on these before that school entry at 4 or 5 years of age, or 6. And this is why it's so important. There's your neuron development, right? Ideal treatment start age is between your 6 months where you have those scattered neurons, that beautifully complex abstract art picture at 2 years of age. But the average treatment start age is only at 3 years. So the early screening, getting them started while you still have a chance to affect that neuronal development and all of those beautiful pathways between 6 months and 2 years is the ideal thing to do. Not waiting till the 3-year-old is only saying 3 words. Don't wait. I had the pleasure of seeing one of my developmental pediatrician friends, who I'm hoping to recruit to come here, who told me that she's tired of seeing 4-year-olds coming in to see her because they're only saying 3 words. They should have been picked up long before that, while we can still affect that development. So what's out there? Again, this is sort of one of those lists that could probably go floor to ceiling, but these are the most popular screens being used by pediatricians across the U.S. And back up, many of these are available in multiple languages. And if you hit the internet, and if you want internet resources, the sites of where you can find the multiple languages, email me, drop me a note, I can forward you that information. But the Mchat we already have in English and Spanish ready to go in our office. You can go online and find it in Creole. You can find it in Nepalese, some of the other more common languages we're finding you can go ahead and keep on hand in your offices so that you could actually give people their language. Many of the languages are validated, some are not. So if you find that every time you give out the one in Creole you're getting waxed answers, it probably isn't, and you might be better off than to sit with the Mchat with the mom and have it translated with you so you can clarify as you go along. But ages and stages, validated in English and Spanish. This is one where you actually purchase the kit, but it's only a couple $100, and then once you purchase the kit, you can copy at will. So it's not expensive. Has beautiful sensitivity and specificity for finding developmental delay in children, and goes across all 5 domains, which are students, residents, 5 domains of development. Communication, yes. Personal, social, yes. Fine and gross motor. Problem solving, good. And so these all include all of those. So these are longer surveys. And then you have the parent's evaluation of developmental status, which matches very well with sensitivity and specificity. And then the Brigance screens, which I have not seen yet, but I just right off the bat, you have 2 that have almost, pushing 85+% sensitivity, specificity. Why drop to 70%? These are not that cumbersome. 6 questions across the 5, so 30 questions for the parents to answer, plus, I guess, is it 10 questions at the end, just asking for more global concerns and letting them free write in their worries and concerns or medical concerns about their kids on the ages and stages. So what do you do with your screening process? That's great. We give out the ages and stages. You can give them out at every visit. The key visits by the American Academy of Pediatrics, remember, 9, 18, 30 months. We chose to keep the 24 months because of our language delay that we were finding there. So this is what you do. This is your family-centered care. We're screening. Screening isn't enough. Interestingly, we've caught ourselves as part of this project as not having documented that we discussed the screening with the parents, which of course is happening, but remember, if it's not in your record, it didn't happen. So make sure you're documenting you discussed that result with the parent. So you're discussing it, you're making a referral if the referral is needed. Tricky part here, I go, your kid needs early intervention. They're 18 months old. I'm not going to see them back for 6 months. Now they're 2. Now those pathways have changed so incredibly much. You're not going to know if early intervention got up with them or not. Sometimes you'll get a letter back from early intervention that says I couldn't contact them, but that's 4 or 5 months later. So you need to figure out what works best for you for triggering yourself to follow up the kids. Recheck them in a month. Have them come back in, recheck their development, talk to the mom, find out what's happened, fine. Phone call in a month, fine. Making sure you're doing a hot handoff to early intervention, calling rather than having your referral coordinators call or having a nurse call, make sure that they're getting that patient may be of help. But those are things you have, I mean, these are practice style questions. So that's not something I can say this is the way to do it. You need to figure out how you best want to follow that up. But I would tell you as you're spacing out your visits, waiting till the next checkup is not going to be appropriate. So waiting 6 months to make sure that they're getting the help they need, you're going to find they've fallen through the cracks many more times than they have gotten that help. These are hard things for parents to face. Nobody wants to know their kid is delayed. So you also have a big component of denial. So they don't call back early intervention. They don't call back. They're not wanting to own that. So it's up to us to help them through that step. Any questions about the developmental? Yes. I don't.
You might be having false positives if you're screening, because usually the push is to screen early.
Right, right.
That's kind of odd that they flipped it to.
Moved it to later, yeah. The question was why the AAP switched from the 24 to 30 months. And actually, it probably should have come up in our 2 days we spent with it, but it didn't. What we were finding more or less is more people are doing more screening than less screening. Many of the practices are handing out the screening at every visit, so it becomes very routine to the patients. Some are super advanced, and the parents are getting them sent to them electronically ahead of time, and it talks to their EHR, and so they're able to have it uploaded into their system from electronic answer. But I think that point that the more routine we're making it, the better accepted it is by parents is probably a really good point. And I think just adding more would be my suggestion than taking less. I don't know why they moved it. But I wonder, in with us saying, well, gosh, we're getting a lot of communication problems that we're picking up at 24 months, maybe that is why. Maybe we were getting too many false positives. But, you know, this is one of those things, once you've identified delay, don't wait. I know I have done this. You know what, I really think your kid's normal. Let's just wait till next time. It just doesn't do anybody any favors to just wait. There is no harm, no foul in going from screening to evaluation, right? Because we're not telling you you have a delay. We're telling you your kid has screened positive for potential delay. If you might have a delay, get that child evaluated. Get somebody to go to the house, early intervention. Sit with the kid, observe the kid. They're not going to be there for just 10 minutes. They're going to spend a couple of hours with that family evaluating and seeing, does the kid truly have delay? So don't wait. If you think there's a problem, act now. And, you know, if parents are easy to talk you into it, Dr. Henchel, I just don't think there's a problem. I don't really think we have to go through all that right now. And I'm not always successful at talking them into go ahead and take advantage of this, but try. See if you can't get them on board. This now, we're moving now from my total comfort zone into, oh my gosh, what are we going to do with all of this? Okay, so full disclosure, this is number 4 on our list. We've talked about maternal depression, autism screening, and developmental screening. This is, to me, where we're getting into gray area and some of what do you do now. A friend of mine who's a non-pediatrician looked at me as we were having a discussion about this and said, yeah, you pediatricians, you always think you can fix everything. And maybe this is part of this, but I really think this is, you know, we're learning more and more about toxic stress and the effect on the developing brain. We're learning more about how we can affect that if the resources are available. And that's where we're moving now with social-emotional development and the other one, the social determinants of health. That one always leaves my brain. So 13% of preschool children actually have mental health problems, 13%. The rate increases with other risk factors, you know, poverty. 70-ish% of my practice has Medicaid. Maternal depression, which we're now going to go ahead and try to identify and help moms with in the postpartum period. But how many times do we have that family that's coming in and we know the mom's bipolar and she's not on her meds, and the front office staff is already telling you that Miss Judy's here, and if Miss Judy doesn't get it together, we need to throw her out of the practice because she is just wild. We need to pay attention to that. You know, because that child is coming in and going home with what your front office has told you they can't tolerate for 5 minutes in the waiting room. So we need to be sensitive to those things. Of course, substance abuse. Our neonatal abstinence clinic is bursting at the seam at times. Some of that is, you know, legitimate pain medication addiction. Absolutely. Some of it is substance abuse. This is happening with our patients. Domestic violence. We've all had patients that are victims of domestic violence. I have a family, I'm almost positive I had the mom abused for agreeing to vaccines one time. You know, it occurred to me that it's not her resistance, it's all the father's resistance, and pushing her to say yes was probably a dangerous thing. So be sensitive and keep your antenna up. And then, of course, foster care. We're doing a lot of foster care intake exams, and that is definitely one of the stresses. So the lists keep getting longer when you look at screening tools for this, but there are a lot of screening tools available to, instead of just using surveillance, which is recommended to be done at every visit, to actually screen for this. There are not pinpointed ages for the screening. I think some of this is knowing your population. My population has a lot of risk factors. Probably very important that I find screening when I want to use the screening and how I want to use the screening in my practice. But of course, this could be tailored. So Ages and Stages questionnaire also comes with a social emotional version. There's an early childhood screening assessment. I love everyone has great in acronyms too. I like PEDS-DM. Parents' evaluation of developmental status and developmental milestones, and that includes your social-emotional. Strengths and difficulties questionnaire I actually particularly like. And if you look at some of the things that are getting passed out for like our ADHD clinic, this is identifying strengths and difficulties. And then survey of well-being of young children. Well, I thought I didn't have enough to fill up an hour. This is the strengths and difficulties questionnaire. It's not so bad. It's not so bad. I would say that this is one of those things that we could actually be using pretty frequently in our population. I know you all can't read it here from the back and wherever else, because again, trying to squish these onto a slide was challenging. But it's really looking at things, what are the strengths and weaknesses of your child, and they're breaking them down into so they're spread out, so you can't pick and choose, hopefully. Emotional problem scale, conduct problems, hyperactivity, peer problems, and then pro-social scale. What are your strengths? Are you considerate of other people's feelings? Do you share with others? Are you the kid who's always looking out for the runt of the class, for the one who's getting picked on and bullied? Do you help someone if they're hurt? Are you kind to younger children? So you're looking at strengths of the kids as well as the other things that might be problems. And so pointing out strengths to families, boy, my kid is on the ceiling. My kid never holds still. My kid's always fidgeting. They just are always in trouble. But you know what? Your kid is the one who's always helping out the rest of the classroom. Your kid does want to please the teacher. Look at the positives that go along with your kid. Don't just focus on those negatives. Look at the strengths that your kid has too. And that's why I particularly like this one. It's not just identifying where your child has problems, but it's also helping you help the parent see where's your kid great? Because everybody's got something. So, social determinants. I did not bring up all the other surveys because they're all out there. You can look at them. You can pick and choose. I like this. I like this, and as we're moving towards having to help our patients identify this, I think probably this is a nice questionnaire. Many of these also fold into the same questionnaire as social determinants, though. So social determinants of health, what are they? And here, thank you, AAP, because really, we think about this. We know it's important. There's forever been a list of community resources in our practice. How many times do I remember to go get it? How many times do I remember to make sure that the mom at the shelter actually does know where to go to get clothes for her family? You know, how many times do we remember to help her with where do you go during the day where you have to be out of the shelter? And so this is all of that. It's your neighborhood and your built environment, health and health care, social community context, the educational opportunities for the kids. Hey, get them in early preschool so they have something to do while you're at the shelter. Economic stability of our families. Really daunting task to take care of all of this. Social determinants of health include all of this. It's a lot, right? Physical abuse, sexual abuse, emotional abuse, physical neglect. Emotional neglect. Is the mother being treated violently? Is there a boyfriend in the home that's beating her in front of the children? Is there substance misuse? Household mental illness? You know, are the parents actually capable parents? Can they do this? Is there separation or divorce? How many of the parents are in the, have been incarcerated? And for us, lots of times our parents are getting sent back to their home countries. Many of our parents are illegal. And the family disruption occurs where the dad gets picked up and sent back, and the dad was the one making the money for the family. And now we have huge stresses on our families. I love this, and I know you can't read any of it. I couldn't either when it was presented to me. But this is the social component. This is the social component down here. It's 23%. Medical care only affects the person 11%. 11%, 23% is social circumstances of our kids is going to affect how is their health. And you also have your genetics and biology. Don't worry, Dr. Doherty, I didn't forget you. 21% is what we're dealt. 11% is what we do for their health care. 7% is physical, and then the 30% is the individual behaviors, behavioral stuff that's going on with the kids. But that's a huge portion. A quarter is this part that's so great to all of us. So I think this is where we really have an opportunity to step up. There's lots of questionnaires again. Many of these are being asked by our nurses on rooming the patients, but we're not using validated screening tools. So they're being asked about food. This is one of the questions that we're asking as we're rooming patients. The hunger vital signs, 2 easy questions. Were you worried about your food would last? Were you worried about you would have money to get your food in the last 12 months? 2 questions. But, you know, when we were starting doing this, the question came right back to us as providers, what do we do when they tell us yes? What do you do next? Luckily, we have volunteered a resident to help us map out our community resources in the, this year, and we're going to make that an ongoing process. We know these are important things, but we haven't built a community of resources to help. So the SEEK questionnaire, the Safe Environment for Every Kid, covers most of the things that were on the previous slide about abuse, drug abuse, security, safety, all of that. And same with the Center for Youth Wellness ACE questionnaire. They do a really nice job of the broad spectrum screening, but easy 2 questions, you can make sure at least your kids aren't having issues with food. There's all the other tools. I mean, this list is forever long. Many of them are not yet validated. So the SEEK is a validated tool and is fairly easy, which probably is where we will head and fits in with the nursing questions. So what do we do now? We've got to get that list of referral contacts. We need to map our resources. It doesn't do any good for me to tell my family what's available in Botetourt, where I live, and I know what's out there because they're on the bus line only and live down here. So I need to understand what's available in their neighborhood, where the food's available, where are the good prices, where can they find things, and following up with the families, making sure that somebody follows up. You know, you were in the shelter. Did you get out? Have you found that you were able to get a safe place to stay? Did the abusive boyfriend move back in? Right? Did the abusive girlfriend move back in? I know we could be the abuser too. You know, what environment is your child in? Follow up with those. Take the time to make sure that you are looking at those toxic stresses. So we've got our work cut out for us there. I challenge us all to step forward in that and do what's best for the kids. It's going to take time and it's going to take effort. And thanks again to the AAP and to Dr. Ryan Fulton for getting us involved in the iScreen project. We are surveying all 4 of the outpatient clinics as to our screening across all of these areas. We are starting with the maternal depression screening as a scorecard measure for ourselves because we hadn't been reliably using a screening tool. We had been doing surveillance. We've been asking and observing. So we're moving to the reliable screening tool. And we're going to be working on this QI project with the AAP. And so it's really exciting. And they've promised us, help us get through all of the social determinants of health and social-emotional health, what to do with it, how to get community buy-in, and how to move forward. So that's what we do every day. Questions?
Any questions in the room? Yeah.
It's not a question, it's more of a comment. I'm just going to go back to the 8 stages questionnaire. And something to remember when we're doing it is not just language issues, it's literacy issues. So they may be able to answer something simply, but it is 60 questions that we're asking them to fill out. So it's literacy and medical literacy. And the other thing to keep in mind is a lot of the questions are cultural. So some of our patients would never think to offer, especially the fine motor questions and the problem solving, like I've never observed that, I've never thought to give this toy to my child. So it is a little culturally biased towards certain populations.
It is, and I think it's sort of generationally biased too. One of the questions in fine motor is stringing beads on a string. Nobody has wood beads in string anymore, so you have to be creative in asking that. I sit on the floor and we take crayons out and we practice doing lines, vertical, horizontal, and circles on some of those because are you kidding? I don't give them crayons. If they write on the walls, I'm going to lose my security deposit. You know, so yes, that's very true. And, you know, we have support staff in the offices most days somebody can give 10 minutes to this family to read to them the survey. And I feel very fortunate, as I'm sure does everyone that works in our office. Our support staff is so good at identifying those people. Many times they've already told me, I'm going to be missing for 10 minutes, I'm going in to read this to Susie. And it's so nice to have that available, but it's challenging too.
Any other questions in the room? I can unmute the phones here real fast. Lots of people on the line this morning.
Oh, yay!
Yay. Okay, if you are on the line, please mute your phone if you do not want to make a comment or ask a question.
The conference is now in talk mode.
Okay, the phones are unmuted. Does anyone on the line have a question they'd like to ask?
I had a question. You had said earlier that about 15% of children have some sort of disability, learning disability, emotional, et cetera. How significant is the skew with that percentage based on socioeconomic status? Is it fairly general, or is most of that 15% going to be in your lower socioeconomic families?
You know, I don't have an answer to that. Mm-hmm. You know, because some of that is genetic, and some of our parents who didn't get help and are now parenting are of lower socioeconomic. I venture to guess that it is higher, where most of us genetically have dealt our kids well, I don't know if I did or not, but, you know, they're being dealt from the parents certainly a certain percent of their potential. And so I think when we're having our low-income families, our low-functioning parents, there is a higher percent. Mm-hmm. But I don't know what that percent looks like.
Okay. I'm wondering how much of the effect is from toxic stress and how much is actually genetic is kind of what I'm asking.
Right, right. And we know that almost a quarter of it comes from the toxic stress, but, you know, we like to think we don't have that in our homes. My house is a split family, so my kids have had toxic stress, and I am not lower socioeconomic most days. And I have a daughter who was passed through surveillance who had learning disabilities because we just did surveillance and we never sat down and did formal screening with her. And so I think that it's really important to focus on kids across the socioeconomic spectrum because there are the kids out there like mine.
Great, thanks.
Thank you for that question. Any other questions or comments on the line? Any other questions in the room? All right. Well, thank you very much.
Go forth and screen.
Okay, if you are on the line and you still have a question, you can always email us, outreach@carillionclinic.org, and I'd be happy to get them, Dr. Henchel. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much.